Dr. Charles Zioki. He's a pediatrician and pediatric endocrinologist in Machakos Level 5 Hospital. It's an honor to introduce Dr. Charles to present this session. Back to you, Dr. Charles. Hello, can you hear me?
Let me see. Okay.
You can start, Doctor.
Thank you. Good evening.
Good evening.
Yes. I hope I'm audible.
Yes, you are.
Okay, thank you. So today we are going to have a look at the long-term complications in children and adolescents with diabetes. And this is going to be the outline of the session. We'll look at the brief introduction. Then we'll look at diabetes kidney disease, diabetes retinopathy, diabetes neuropathy, and diabetes food. Type 1 diabetes is a lifelong condition, and being a lifelong condition, it comes with its own challenges. And among those challenges is the risk of what we call the long-term complications, which is secondary to microvascular and macrovascular issues. And so for these complications tend to take years to develop, so they'll be seen later on as the disease progresses and of complications.
Hello, you're breaking, Doc. Hello. We can't hear you. Sorry for the network interruption. Doctor is using another internet option to join. Please stay tuned.
I'm sorry, members, for the network disconnection. So we are looking at the long-term complication. I hope I'm now audible.
Yes, you are audible.
Okay, thank you. So as we had started saying that they tend to take many years to develop, and they have been related to the degree of glucose control. And in this case, the glycosylated hemoglobin has been an important factor in terms of a predicator of the risk of complications. And because of this one, then it's important to have early control in childhood. And this one is just what we call the metabolic memory. Research has shown that good control early in disease tends to, those benefits are carried forward in the long term. And so it's important to ensure control is achieved as in the earliest part of the illness. The complication due to injury to the blood vessels, and of note is that for us to be able to mitigate and prevent the onset of this complication, then intensive education and the treatment is key. So we need to ensure that our children undergo intensive education on self-care, and that we need to optimize the treatment to ensure as good glucose control and HbA1c as possible. So these long-term vascular complications of diabetes are basically divided into what we call the diabetic kidney disease, then diabetic retinopathy, diabetic neuropathy, and we have microvascular conditions, especially the strokes and heart conditions. And if not well taken care of, the net effect of this long-term complication would be kidney failure and hypertension due to the diabetic kidney disease. Visual impairment and blindness is a common result of diabetic retinopathy, and then pain, paresthesia, and also sensation due to the peripheral neuropathy. And apart from the peripheral neuropathy, we also have autonomic neuropathy, and this patient would present with postural hypotension, gastroparesis, diarrhea, bladder paresis, and impotence. Cardiac disease, peripheral vascular disease, and stroke due to microvascular disease is also a part of the long-term outcomes of these complications. What are the risk factors? As I said, the main risk factor for this complication would be hyperglycemia. In this case, when glycemic control, high HbA1c, and high variability in the daily blood sugar readings would be a marker of increased risk, tends to increase the risk of these complications. Age and duration of disease, the older the patient, the higher the risk. The onset of puberty have been shown to coincide with the onset of complications, and the longer duration of the illness, because some patients will tend to lose that long-term control because of the psychological issues and mental issues secondary to the long-term nature of diabetes. Then we have genetic and lifestyle. The complication have been noted to be higher in the female gender, and those with familial risk, especially the microvascular conditions and the smoking. And then cardiometabolic risk factors, being overweight, being obese, having uncontrolled hypertension, and those with the dyslipidemias. So let's start by looking at diabetes kidney disease. Diabetes kidney disease is a major cause of morbidity and mortality among patients with diabetes. And it's as a result of both morphological and functional changes to the nephron. And the main feature is the increase in albumin expression rate. So albuminuria is the earliest clinical manifestation of diabetic kidney disease, and it's the key risk factor for progression over proteinuria and end-stage kidney disease. So normally chronic kidney disease is defined as abnormality of kidney structure or function, which is present for more than 3 months, 3 to 6 months. and it can be classified on the course, can also be classified in the glomerular filtration rates, grade 1 to grade 5, and the albuminuria category A1 to 3. And these are according to those guidelines. Currently, chronic kidney disease, which is basically attributed diabetes, is now referred to as diabetes kidney disease. So we have seen albuminuria is a major risk factor for progression of renal disease, and we confirm the presence of albumin in urine by finding 2 or of 3 samples abnormal over 3 months to 6 month period. What this says that we need to take at least 3 samples in this duration of 3 months to 6 months, and if 2 or the 3 are positive for albumin, then that one is a confirmation of albuminuria. And if it's persistently increased, and that's with every test, the levels are going up, then it's a predicator of progression to kidney failure. And it has also been associated with an increased risk of microvascular disease and also mortality. So what's albuminuria? So there are several classifications or categories of albumin. You have seen grade 1 to grade 3, and moderate increased albuminuria, formerly what we used to call microalbuminuria, as an albumin is defined as an albumin expression rate of between that and 300 milligrams over 24 hours, or 20 to 200 micrograms per minute in 24 hours, or time to urine collection, or when you do an albumin creatinine ratio between 3 and 30 milligrams per millimole. That's that to 300 milligrams per gram. And if it progresses, then we go to what we call the severely increased albuminuria, which used to be called macroalbuminuria or stage 4. In this case, the albumin expression rate is more than 200 micrograms per minute, or more than 300 milligrams over 24 hours. There are an albumin creatinine ratio of more than 30 milligrams per millimole. If you are using the other units, more than 300 milligrams per gram. And once we have moved to beyond the sphere form of albumin secretion, then we go to stage 5, which is basically the kidney failure. So then we need to screen our patients and take action to prevent this progression of kidney disease. And this is the latest guideline from the National Society for Pediatric and Adolescent Diabetes, the 2022 guidelines on screening for kidney disease in children and adolescents. So for type 1 diabetes, we need to start screening any child who is diagnosed at 11 years of puberty, and any child with diabetes of at least more than or equal to 2 to 5 years. For type 2 diabetes, screening is supposed to be initiated at the point of diagnosis. So once you have started the screening, then we need to do an annual urine albumin creatinine ratio, and the morning urine is basically preferred. We can also do serum creatinine to calculate the estimated glomerular filtration rate. So you can either screen using the SCR or the estimated glomerular filtration rate. If the SCR is less than 3 milligrams per millimole, and the estimated glomerular filtration rate is more than 90 mL per minute in 1.73 square meters, then this is a patient you need to do continuous follow-up and then do an annual urine for SCR, and the first morning sample basically preferred. However, if on the first screening, the SCR is more than or equal to 3 milligrams per millimole, then we need to repeat 2 additional samples in a period of 3 to 6 months. And if these 2 out of the 3 samples are have less than 3 milligrams per millimole of SCR, then this child will go on routine follow-up with an annual screening. However, if the 2 of the 3 samples have a rating of more than or equal to 3 milligrams per millimole, Then this is a child whom we need to intervene. And the first intervention is that we need to optimize the glycemic control and ensure we achieve as good control as possible in terms of the daily sugars and HbA1c. Then we need to monitor the blood pressure and optimize the BP. And we need to look at the lipid levels, and if possible, we also need to start managing the lipid if need be. Then these are children whom we need to start on SCB inhibitor. And basically, with continuous checking of the blood pressure, the serum potassium, creatinine in 2 weeks from starting on SC inhibitor because of the side effects of SEs. If on the other hand, you did our first screening test and SER was more than that milligrams per millimole, or the extended GFR was less than 90 mils per minute, then this is a child whom straight away we need to refer to pediatric nephrologist for workup for other non-DKD etiologies. Most likely, at this age, we don't expect them to have gone to this point of severe compromise. So these are some questions we need to rule out other issues as a cause of the renal disease. So what are the key points? The first thing is that to diagnose albuminuria in children in diabetes, we ensure, first of all, that it's not orthostatic. And this is why the morning urine sample is preferred, because if you take it during the day, it's affected by other issues like activity and a few other parameters. And two, the other issue is that the presence of 2 positive samples out of 3 is a diagnosis of albuminuria. And this is a summary of the screening process, as we have said. When to start, age at puberty, or 11 years with 2 to 5 years duration of diabetes. You have said for type 2 diabetes, we start a diagnosis, and the frequency is annually, unless unless they meet the diagnosis of treatment, as you have seen in the previous diagram. So what are the methods of screening? Basically use urinary albumin creatinine ratio, and the first morning urine sample is preferred. And the risk factors are uncontrolled blood pressure, lipid abnormalities, and smoking. So these are risk factors which we need to assess every time the child faces and see how we can mitigate and manage these conditions. And the main intervention basically is improved glycemic control and lowering the blood pressure using either an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker. For children with type 2, this is basically for type 2, we can use the sodium glucose co-transporter inhibitors and glucagon like peptide 1 inhibitors. But basically in type 2 diabetes. As we know, nowadays we're having some of our patients coming with type 2 diabetes. So you can use these 2 molecules as part of the intervention in that group of patients. Let us look at the diabetic retinopathy. And this is a progressive and it's a potentially sight-threatening disease of the retinal neurovasculature. And the main risk factors are the duration of diabetes. The longer the duration, there is the risk of retinopathy. Then the other issue is optimal glycemic control, uncontrolled blood pressure, and uncontrolled albumin expression in urine. So chronic hyperglycemia tends to cause tissue damage in the blood vessels of the retina. So the main cause of this diabetic retinopathy is the effect of high sugar on the endothelium or the retinal vascular structures. And this damage to this endothelium, to the endothelium will result in abnormality of permeability of the vascular such that they start leaking. Then it can end up with occlusion, with ischemia because of the changes and the thrombosis and the clotting occurring. And then these changes can lead to further, because of the damage to these vessels, we end up with revascularization. And all these three parameters we tend to coalesce together and result in retinopathy. So basically it's classified as non-proliferative diabetic retinopathy. Then there's the proliferative level, and then the diabetic macular edema or the maculopathy. The non-proliferative diabetic retinopathy, the main feature is microaneurysms of the retinal vasculature. We also have retinal hemorrhages and what we call the cotton wool spots and heart exudates due to leakage of lipids and other solutes in this solutes from the blood vessels. So in the mild form or the non-proliferative diabetic retinopathy, the only thing which is present is the microaneurysms. But by the time we move to moderate stages, it's a microaneurysm. And normally at the mild stage and moderate stage of the non-proliferative diabetic retinopathy, we have no risk of vision loss. However, the moment we move to the severe form, and this is what we used to be called the proliferative stage in the past, we have vascular obstruction and a worsening of the retinal hemorrhages, the worsening of the microaneurysms, marked venous abnormalities, and because of these vessel changes, ischemia and infections of the retinal nerve fibers, and we end up with what we call the cotton wool spots. All these factors together would increase the risk of visual loss in these patients. Then from the non-proliferative phase, we end up with the proliferative diabetic retinopathy. And the main issue here is that now we have neovascularization in the retina. The initial phase resulted in changes and ischemic changes basically affecting the vessels. So now we are forming new vessels in the retina and also in the previous posterior surface. And this increases the risk of visual loss basically through the vessels rupturing with bleeding to the retinal space, and sometimes fibrosis and contraction, which results in traction or retinal detachment. And once we have this one, we end up with what we will be irreversible blindness. So at this point, once the retina is touched, then most of the time we are unable to reverse this blindness. Then the diabetic macular edema or maculopathy is basically due to a decrease in vascular competence. Basically, we have a lot of permeability of the vascular structure, and we have leakages through the blood vessel walls, and this leakage is what causes edema at the macular level. It's also associated with microaneurysms, and the net result is basically exudation and the swelling of the central retina and the risk of visual loss. These are some pictures showing a standard normal retina from a fundoscope. Then this is another picture, a normal retina. And in this case, we have the proliferative phase. You can see the new vessels which are forming, these exudates, and the change in the architecture of the blood architecture within the eye. Then in the non-proliferative phase, basically, we say the main issue is microaneurysms. But when we look at the vessels in the last corner, you can see there are some bleeding and also some changes within the eye, and the vessels become tortuous, and we seem to have leakages and some element of bleeding into the eye. And this is the proliferative phase. You can see now the vessels increase in number. Like in the last diagram, we have too many new vessels which are formed in the eye. So the only way to prevent diabetic retinopathy is to screen and intervene And when do we start the screening process? Basically, according to the ESPAT guidelines and the ADA guidelines 2023, we need to start it once the child is at least 11 years with 2 to 5 years of diabetes duration. And all children diagnosed with type 2 diabetes should be screened at the point of diagnosis and need to be repeated every 2 to 3 years. This repeat of 2 to 3 years is the current ADA guidelines. And the method of screening is basically fundal photography. And if we are able to do the fundal photography, we can do amyotrophic ophthalmoscopy. And the risk factors for retinopathy, basically hyperglycemia. So good blood glucose control is key. The question also uncontrolled blood pressure. So we need to control the blood pressure as well. Lipid abnormalities, and it has also been associated with the higher BMI. What are the main interventions which we need to do to prevent the progression? The first one, and which is key, is improved glycemic control. And if we have the changes, then we can do laser therapy. And for patients, especially type 2, we can still wear the active growth factor into the eye, the anti-FEGF into the eye, which means in either the proliferation or the new blood vessels. Then we move to diabetic neuropathy. And it tends to affect both the somatic and autonomic components of the peripheral nervous system. And initially, it's the small and myelinated nerve fibers that carry pain and temperature. And later on, we have injured to the myelinated nerve fibers, which convey vibration and position sense. And because of the effect on the pain and temperature, you will find that the first presentation is often the third burning sensation described as talk and graph pattern, which is the main presentation of diabetic neuropathy. We also have the autonomic system being affected, and the main organs which are affected are basically the cardiovascular, the GIT, and the pseudomotor system. And clinically, this patient will present with arresting state tachycardia. They'll also have exercise intolerance and the gastroparesis, which is very common. They'll come and tell you they're always full. And then because of the pseudomotor effect, they'll have dysfunction of sweating response. So, and we screen for neuropathy. When do we start? 11 years of age with a 2 to 5 years of duration of diabetes. What type 2 diabetes basically is at the diagnosis, and the frequency is supposed to be done annually. And what are the screening methods? Basically, history, you look to try to get good history to elicit features of neuropathy. We need to do a good physical examination. They can do clinical tests, the pinprick sensation and vibration sense, also part of the assessment we can do. And most clinic will use the monofilament testing. What are the main risk factors? Basically, glycemic control, uncontrolled blood pressure, and hyperlipidemia. And the intervention, like in the other parameters, the first one is optimized glucose control. Then we need to do serum lipid control, optimize blood pressure if the patient has uncontrolled pressure. And because this condition tends to present with pain, then we can employ pharmacological management for the pain. Then we are going to touch briefly on foot care. And when you are assessing these patients and you are interested in the neuropathy and especially the question of the food, there are key issues in the history. The duration of diabetes we have seen from the beginning is key. The longer the duration of diabetes, the risk of complications. We need to assess how the patient has been controlled in the past. The medical history of whether the patient had a prior foot injury, a history of previous others of amputations, a sign of previous neuropathies and other issues. Then we need to assess for microvascular and the microvascular disease, claudication, then the neuropathy, and it's important to look for cigarette smoking because it has been noted to be one of the main factors which increases the risk of all these complications. So we need to examine the feet carefully anytime the patient presents, because often this is one of the main reasons why most of the patients come to the hospital. And the first examination is that we need to look for other general conditions of the extremities, where there are any areas of injuries, where there are any calluses, and whether there are any fissures and other issues whereby we have increased risk of ulceration, or a process which has already started, and because of the loss of sensation, the patient has not been able to recognize it and act on it. And then we need to assess the possibility of vascular insufficiency, because vessel and blood supply to the cerebrals is a key issue, and we are interested in the pedal passes, the skin structure, and whether we have good blood supply to the toes. And then we assess the possibility of a peripheral neuropathy, and we address the different reflexes, the state of the muscles, the presence of a tooth drop, and excessive callus formation, which might be a sign of continuous pressure with loss of, which would result from loss of sensation in particular areas of the foot. So how do we examine the foot? Basically, we need to look at it in this order. You need to look at the skin dermatological. We are addressing the skin state, whether we have infection. And the infection, we need to check between the toes and the fungal infection, which is a common issue in diabetes and controlled diabetes. You need to check for ulcers, calluses, blistering, and also bleeding to the callus. Then once we have ascertained the state of the skin, then we need to look at the musculoskeletal structures. You need to look at the status of the feet and the toes, interested in deformity, and the state of the muscles, whether we have wasting, especially between the metatarsals. Then we need to assess the neurological state by using the monofilament, and you can also use the vibrator, as well as that and any other tuning fork to test for vibration sense. You can use the pinprick sensation, and then the angle reflexes and vibration perception threshold to assess the nervous state or the neurological status, the nerve status of the feet, and then we look for vascular compromise, basically the foot passes and the ankle brachial index, if indicated. So this is just a picture showing how we need to examine the feet, because often a lot of issues and complications come through the foot. This assessment for circulation and protective sensation, basically the pinprick sensation, the monofilament. I think most of our units have the monofilament. Then you can use the pinprick sensation, and we can assess for the passes to see whether we have a good vascular, a good blood supply to the feet. So for the action to be taken would depend on the finding of the food, but it needs to be part of the continuous assessment at the time the patient comes in, and part of continuous education on how the patient should take care of his or her feet. Those are the references to these guidelines or to this talk. Basically, it's about clinical guidelines 2022 and the ADA standards of care 2023. And I need to acknowledge a project I work with the PenPress for some of the, and CDS for some of the slides I've used. Thank you.
Thank you, Doctor, for that great presentation. It was comprehensive and timely. Questions are now open to be asked. There is one question on the chat box. It says, please explain further on SGL2 and the glucagon-like peptide transporter, the glucagon-like peptide on DKD, diabetic kidney disease. I think he has corrected. Initially, it says in type 1 DM on insulin. Explain further on the SGL2 and the glucagon-like peptide on diabetic kidney disease. I think he's asking, is there any place of those two drugs?
Okay, thank you for the question. We have talked about the GLP, glucagon-like peptide, and the other one was the GLP, the sodium glucose co-transporter inhibitors, basically. These are patient drugs which are meant for patients with type 2 diabetes, not type 1 diabetes. And they are part of the medication to improve control in these patients and have been noted to reduce the rate of progression of kidney disease in these patients. So the sodium glucose co-transporter inhibitors and the glucagon-like peptide inhibitors have used, but only type 2 diabetes, not in type 1 diabetes.
Yes, thank you, Doctor. We have time, so if you have any more questions, you can ask. Only this question is on the chat box. Maybe if there is anything you want to clarify, Doctor, until they think and ask a question.
I think the only thing which I need to emphasize is the control of sugar as the main way to prevent the onset of these complications. So we need to optimize our glucose control by putting our children on the right medications. Still, we have a lot of our children on premixed insulin mixed and it does not achieve good control. So if it would be possible, we need to shift our children to more dose regimes and try and work around it to optimize the glucose control. And the other issue is not to forget that we need to be assessing these things anytime the child comes in. And the importance of the screening for complication cannot be underemphasized, because often you will find somebody who comes to the clinic and comes very late, they have lost their sight, and they have kidney failure. In my clinic, I have a few who are 22, 23, 24 years, who are on at least one who is on dialysis and another one with complete visual loss. So it's important to emphasize and educate the patient on the need of good control of the sugars. And then we look for these we screen for this complication anytime we have an opportunity to be with the patient. Thank you.
Okay. Yeah, so there are some questions now on the chat box. So Rosemary asked, is it possible to reverse the abnormal microalbumin levels?
Yes, that's why we are doing the screening. So once we make a diagnosis of an abnormal albumin in urine, then the next thing is to take the corrective factors or the preventive factors. And the most important factor we have said is glucose control. If the child was not well controlled and we are able now to achieve good HbA1c, good blood sugar readings, you'll find that this progression of kidney disease can be stopped. And so it's important to ensure that one. The other issue which I've seen is that for some cases whereby the pressures are high or the albumin levels are high, there are medications which are meant to reduce that progression. And basically the drugs which you need to use are the angiotensin converting enzyme inhibitors and the angiotensin receptor blockers. They have also been shown to have benefit in preventing the progression of the albuminuria.
Yes.
I hope I answered that. Yeah.
Yes, it's clear. So there's another question from an anonymous attendee. He asked, apart from managing the underlying risk factors, do nerve supplements play any role in management of diabetic neuropathy? I think he's saying nerve supplements. Is it the medication we give for neuropathy? It's not clear on the question, but.
Okay, thank you, Doctor. Doctor, I really don't understand, but the fact that we have talked of nerve supplementation, it means some of these supplements being sold in the shops.
Yeah.
That's my thinking. And I'm not conversant with them, so I would not be able to say much about it unless somebody else in the panel has some experience with them. Can also comment, but personally about the supplements, I'm not able to say much about that. Thank you.
Thank you. Maybe Dr. Preska is on the panel. Do you have any comment on this?
Good evening. No, I do not have any experience with nerve supplements, and I haven't come across any research or studies that have been done on the effect or effectiveness of nerve supplements. So maybe that's something we can look up and give you feedback in the next session.
Thank you. So there is another question from Anne. How do we optimize glucose control in pre and adolescent without compromising growth?
Okay, thank you for the question. Ideally, we need to ensure good control right from the beginning, and through appropriate and meticulous insulin titration and also good nutritional management, you can be able to achieve very good control without compromising normal growth. We remember that all children must grow and they must grow normally. And one of the reasons children with diabetes don't grow normally is when we don't have good control. Failure of good control itself is a risk factor for abnormal growth. So each case has to be individualized. And as we have said, most of the times, the mixed or the premixed insulin will not be able to give you that control because you are unable to adjust the various components depending on the situations as it demands. So if you can put our children on more dose injections, if possible, the long-acting and short-acting, that will be able to adjust and optimize on nutrition to ensure good control and good growth at the same time. I don't know whether Dr. Priska, you have something else to add?
No, nothing to add.
Okay, thank you.
Okay, thank you. There are two questions from anonymous attendee. With good glycemic control, is it 100% guarantee of not getting chronic complication, or is it only delays? And the other is CKD or diabetic kidney disease reversible?
Okay, thank you for the good questions. Good control reduces the risk, but I don't think there is anything which will give you 100% guarantee that you do this one, you cannot get kidney disease. So, but the risk of progression to kidney disease is much reduced from the studies which have been done by having a good glycemic control. In this case, we are talking about very good HbA1c and minimal variability. Of course, with the meticulous management of the other risk factors. But all that, all said and done, it cannot be 100%, but but we'll guarantee 100% protection against anything. The second question was about what? I've forgotten.
Is it diabetic kidney disease reversible?
Okay, in this case, I think they're asking about the end stage, chronic end stage renal disease. That's basically stage 5. Stage 5 is not reversible. Once you're in stage 5, you have to go to replacement therapy. That's basically the dialysis. So the other stages can be mitigated, but once you have ended with the CKD, the stage 5 disease, it's not possible to reverse it.
Thank you, Doc. So I think these are most of the questions that have been asked. There are some comments who say great presentation. So I think if there is no further question, we can end up the class here. But if nothing, if there is anything you want to add, you can add now.
Okay. Sorry. I don't think I have anything more to add. Maybe Priska, do you have something more to add?
No, but I can see one question. I'm not sure if you asked. Someone asking, is it advisable to put patients on angiotensin receptor blockers or ACE inhibitors who have diabetes, who are not hypertensive, or diabetes hypertension combination? Dr. Antioki, do you want to take that? Or we could invite, I saw Dr. Syriac in the meeting. I don't know if he's still there.
I can invite her. I think I can take over the question. From this, the latest guideline, we put them on the SE or ARBs only once we have abnormal albumin creatinine ratio, we have albuminuria, and it's a part of a package of care. It's not by itself, and by itself. So the first thing is optimization of the blood glucose, need control, the blood pressure and lipid levels. And then the SE inhibitors themselves have been shown to have a beneficial effect on the renal microvascular structures and an improvement of prevent the progression of the renal disease. So SEs and ARBs can be used, but only when we have evidence of an abnormal renal function. If the kidney is functioning, there's no albumin in the urine, and the blood pressures are well controlled, then we don't need to start them. We start them only when we confirm albumin in urine by use of 2 to 3 samples, whereby of the 3 samples, 2 must be positive.
Okay, thank you. We managed to add Dr. Syriac to the panel. Dr. Syriac, would you like to make a comment on the question on use of ACE inhibitors and ARBs? You can unmute yourself. Okay, I think he's not able to unmute. So, Dr. Hiwot, back to you.
Okay, thank you. So there is one final question. Maybe we can answer this one. What is the best description of type 1 and type 2 DM? I always confuse them. Kindly please answer. It's from anonymous attendee.
Okay, thank you for the good question. So basically type 1 diabetes, the main issue in type 1 diabetes is that these children have no insulin and they are insulin dependent for their survival. So that's the basis of type 1 diabetes. In type 2 diabetes, not very common among children and adolescents, not very common in our setup, but we need to be aware that it occurs and be on the lookout for it. And basically, it's just like in the androids, whereby they have insulin, but the insulin has some issues with the action. So there's increased resistance, the insulin is not working well, or we can end up also with some reduction in the amount of insulin, but they have some insulin. So that's the difference between the two. One has no insulin, the other one has insulin, which might not be working well or at a reduced level.
Yes, thank you. There is a question which comes again. If we can comment on it. Is there any future in stem cell transplantation for beta cells in type 1 DM? I know it's not the topic of this discussion, but if you have any comment, you can.
That's a good question. It's a futuristic question. I think stem cell research is still in infancy, and we cannot say with certainty what will happen and not happen. I think we cannot wait and see what research brings along. That's the much I can say. Unless anybody else can add something more.
I think that's okay. So we'll end up today's session. It was a great presentation and great discussion. Thank you, Doctor. Thank you all the participants for participating in today's session. We'll continue our diabetic series from next week. Have a good night.
Okay, thank you. And thanks to all the participants.